Hi, everyone. Just wanted to introduce myself. My name is Michelle Guerrero, and I am a PGY2 infectious diseases pharmacy resident at Memorial Hermann Texas Medical Center. Thank you for allowing me to lecture opportunistic infections to you all. And unfortunately, we weren't able to meet in person, but I have prepared this recording for everybody. And if anyone has any questions, feel free to email me. My email is going to be available at the end of this lecture. And so today we will be going over opportunistic infections with an emphasis on treatment in HIV patients. Here are the objectives for today's lecture. And so by the end of this lecture, we should all be able to describe the common pathogens that are associated with opportunistic infections or OIs in immunocompromised patients, differentiate between prophylaxis and treatment for different OIs, as well as recommend appropriate prophylactic regimens and treatments for common OIs. So let's start off by defining what an opportunistic infection is. An opportunistic infection is an infection that usually has low virulence profiles, but can cause severe infections in patients who are immunocompromised or those who have weaker immune systems. So an organism that would otherwise not cause an infection in a patient with a healthy immune system will likely occur in those that are immunocompromised. And so opportunistic infections essentially take advantage of a weakened immune system. It's important to also understand the differences between someone who is immunocompetent and someone who is immunocompromised and how each group responds to exposure to a foreign organism. Immunocompetent patients are those who have the ability of producing a normal immune response following exposure to an antigen. And so this essentially allows them to mount an adequate immune response against these opportunistic infections. And these patients have a strong enough immune system to overcome OIs. An immunocompromised patient is one who fails to respond adequately to infection, whether it be because they have an autoimmune disease, or maybe they're on immunosuppressants, or they're receiving chemotherapy. And so these patients are going to be the ones that organisms take the most advantage of. And as I mentioned, some of these opportunistic infections are typically of low virulence, which are mostly non-pathogenic in those that are healthy immunocompetent patients. But in immunocompromised patients, it will present as a more serious and oftentimes even life-threatening infection. So who are those that are most at risk for developing opportunistic infections? Patients with HIV or AIDS have the greatest risk for opportunistic infections, and this is actually where most of our OI treatment data lies. And next, we have some cancers itself, such as lymphomas and leukemia, can alter a patient's immune system, predisposing them to opportunistic infection risks. But other than just cancers itself, cancer medications are immunosuppressive that try to inhibit growth of tumor cells as well as normal cells. So this also increases the risk of opportunistic infections from occurring. Chemotherapy also puts a patient at risk for opportunistic infections because not only will they kill cancerous cells, but they will also kill off our normal cells. And most importantly, it will cause neutropenia, which is our neutrophils that are immune cells that will fight off infections. And so the period where we have the least amount of neutrophils, this is called nadir. And when nadir occurs, this is where the patient is actually the most vulnerable to infections. Next are corticosteroids. This puts a patient at risk for opportunistic infections because they possess many anti-inflammatory as well as immunosuppressive effects. But most importantly, corticosteroids that are used long-term and at high doses predisposes someone to opportunistic infections. Most specifically, prednisone equivalents of 20 milligrams a day for more than 2 weeks. And lastly, patients who receive donor transplants, especially solid organ transplants, are at a high risk of nosocomial opportunistic infections, especially in the early post-transplant period. And they are also at risk for opportunistic infections throughout the rest of their lives while they are taking multiple immunosuppressants every day. And so just keep in mind for the rest of the lecture, we will continue to focus on opportunistic infections, specifically in HIV patients. So for HIV patients specifically, immunosuppression occurs on multiple fronts. Our innate immunity is our first line of defense against infections, and HIV cells can evade as well as disrupt our immune system. And with HIV viral replication and viral load increasing, this further suppresses a patient's immune system from fighting back. And HIV cells also causes a loss of CD4 cells as well as T lymphocytes, which are key players in mounting an immune response. And HIV does this by attaching to the CD4 protein on the surface of CD4 lymphocytes. And it will also use this to gain entry and use that CD4 cell to replicate more viral DNA. And CD4 lymphocytes are important in stimulating killer T cells, macrophages, as well as B cells to the site of infection. And without this, with the CD4 count decreasing due to HIV cells replicating, and being depleted by HIV cells, the more at risk you are of developing infections. And so opportunistic infections can be caused by bacteria, viruses, funguses, as well as parasites. And this isn't an all-inclusive list, but these are the most common opportunistic infections that can occur. So as for the bacterial opportunistic infections, infections include tuberculosis, bacterial respiratory, as well as enteric infections, as well as non-tuberculous mycobacterial infections. Among the viral OIs, the ones that can occur include varicella zoster, herpes simplex virus, cytomegalovirus, human herpes virus that causes Kaposi sarcoma, as well as human papillomavirus. The most common fungal OIs include candidiasis, cryptococcosis, and pneumocystis jirovecii pneumonia. And among the parasitic opportunistic infections, this includes isosporiasis, microsporidiosis, cryptosporidiosis, giardias, as well as toxoplasmosis. So focusing on opportunistic infections in HIV patients specifically, with CD4 cells continually being depleted by HIV cells, it puts patients at risk for certain opportunistic infections at different CD4 levels. So keep in mind, a normal CD4 count is about 500 to 1200 in healthy patients, but in HIV patients, this is much lower. And so at a CD4 count of less than 500, HIV patients are at risk of infections such as tuberculosis, Kaposi sarcoma, as well as herpes zoster. At CD4 counts less than 200, we are concerned for pneumocystis infections and even mucosal candidiasis. At CD4 counts of less than 100, we start to then think about cryptococcosis, mucosal herpes simplex, as well as toxoplasmosis. And once the CD4 count drops now below 250, we start to worry about cryptosporidiosis, CMV, and MAC infections. Opportunistic infections can be prevented as well as treated when they occur. So differentiating between what prophylaxis and treatment is, it's important. So prophylaxis is essentially preventing the infection that a patient has risk for. And there are two types. There's primary prophylaxis and secondary prophylaxis. And for primary prophylaxis, this is when a patient is at risk for an infection, but they have never had the infection before. In secondary prophylaxis, this is when a patient had the infection before, but they need to prevent the recurrence of that same infection. And as for treatment, it's straightforward and self-explanatory, but for completeness sake, it is when a patient is diagnosed with, in this case, an infection, and we are trying to either eradicate or control the disease or the pathogen. Since opportunistic infections occur most often in HIV patients, we will be focusing on this for the rest of the lecture, and these are the most common organisms that we will go into depth on today. So the first one is pneumocystis jirovecii, Toxoplasma gondii, Mycobacterium avium complex, Candida albicans, Cryptococcus species, as well as cytomegalovirus. So we'll go ahead and jump to the first organism for today, and that is Pneumocystis jirovecii. And the opportunistic infection that is most commonly caused by this organism is Pneumocystis pneumonia. So Pneumocystis jirovecii is a fungus, and it can cause pneumocystis pneumonia in immunocompromised patients. And note that the infection PJP is also commonly referred to as PCP. And that is due to the fact that this infection was initially isolated from Pneumocystis carnii, but the name change was done in the early 200s since P. carnii is actually now known as the species primarily found in rats, and Pneumocystis jirovecii is a species found in humans. So you'll hear it being interchanged a lot in terms of the infection. PJP, PCP, both are accepted terms. So the trophic form stays primarily in the lungs, and this is actually where the organism will multiply. And it multiplies through binary fission, and it has a cell membrane that is actually pretty weak and fragile. When it turns to the spore form, this is actually formed by conjugation of two different trophic forms. And with that, it develops a more rigid cell wall that gives it the protection that it needs to be able to go out into the environment. And it's actually gives them protection against environmental conditions, and it makes it suitable for transmission. It has excellent growth, especially in the alveolar epithelial cells. And the amount of fungus that grows actually correlates to the degree of immune dysfunction. So the more immunocompromised an individual is, the more likely that they are able to grow more concentrations of P. jirovecii. P. jirovecii is transmitted primarily through airborne spores, and it is quite ubiquitous in the environment. So when someone is infected with P. jirovecii, it mainly presents as a pneumonia. And clinical presentation includes subacute fever, non-productive cough, tachypnea and tachycardia, dry rales, and hypoxemia, most notably with the PaO2 of less than 70. Oftentimes, you will also see that a lactate dehydrogenase is greater than 500, but keep in mind that this is not specific to the disease. Also, seeing extrapulmonary sites is rare, and it is most commonly located and isolated in the lungs. As for diagnosis for PJP, CT scans are more sensitive than chest x-rays, but it may show typical changes in patients with negative chest x-rays. So in chest x-rays, you'll typically see bilateral infiltrates. CT scans, you'll see ground glass opacities. And for other different diagnostic tests used to identify PJP, you can use a direct fluorescent antibody stain or DFA. And this is shown in that left picture where you see the green fluorescent lights. And another type of stain that is commonly used is also a GMS stain, and that's the picture that you see on the right. Both are different methods of staining done in the microbiology lab. PJP can also be visualized in lung biopsies, at least commonly, but is still also used through PCR. Different specimens are collected for these diagnostic tests, and different specimens include bronchial alveolar lavage, or BAL, and sputum induction. And the difference between the two is that a BAL is basically a bronchoscope that is being passed through the mouth and into the lungs, and the fluid is squirted into the alveoli and recollected for examination. And so that is what is typically put into these stains and seeing if it grows. And then sputum induction is basically when a patient induces their own sputum. So as for therapy, for treating PJP, the first line therapy is going to be trimethoprim sulfamethoxazole or Bactrim. And the dosing regimen is 15 to 20 milligrams per kg per day, either PO or IV. And this dose is going to be divided into Q to 6 8 hours. Or if not using a weight-based dosing, you can do Bactrim 2 double-strength tablets, PO, 3 times a day. And just to keep in mind, a double strength is 160 milligrams of the trimethoprim content and 800 milligrams of the sulfamethoxazole content. And for alternative options, this includes primaquine 30 milligrams PO daily in conjunction with clindamycin 450 milligrams PO Q6 or 600 milligrams Q8. Another alternative option is atovaquone 750 milligrams PO BID, but keep in mind that this has to be taken with food. And lastly, you can use pentamidine 4 milligrams per kg IV daily, but this is usually reserved for more severe cases. And PJP treatment duration is going to be 21 days. And just keep in mind for dosing for Bactrim, the dose is going to be based off of that trimethoprim content. So the 15 to 20 mg per kg is going to be based off of the trimethoprim. And so there is a role for steroids in PJP treatment. So corticosteroids used in conjunction with PJP therapy decreases the incidence of mortality as well as respiratory failure in those with PJP, especially when a patient is hypoxemic. And patients who are hypoxemic and without steroids may actually worsen after only 2 to 3 days of PJP therapy. And so the mechanism of this worsening occurs due to the fact that there is increased inflammation from dying P. Girovechi organisms. So there is a high burden of these organisms during infection, and as they die off due to therapy, inflammation occurs in the lungs, and this causes respiratory failure. So steroids are typically initiated in patients who have a PaO2 of less than 70. And the therapy is as follows for prednisone. Prednisone 40 milligrams BID times 5 days, followed by a taper of prednisone 40 milligrams daily for 5 days, followed by prednisone 20 milligrams daily, and that is going to be continued for 11 days. And when we talk about primary prophylaxis for PJP, there are specific criteria that need to be met for when we start as well as discontinue their primary prophylaxis. So initiation is going to be started when CD4 count is less than 200 cells. And we can discontinue primary prophylaxis when CD4 counts is greater than 200 for at least 3 months. And when it comes to the therapy used for primary prophylaxis, first line is going to be Bactrim again, but the dosing is going to be different from therapy dosing or from treatment dosing. So Bactrim primary prophylaxis therapy is going to be 1 double-strength tablet, PO daily, or 1 single-strength tablet, PO daily. And just keep note in terms of the individual components, single strength is going to be 80 milligrams of the trimethoprim and 400 milligrams of the sulfamethoxazole. There are alternative options available, and this includes Dapsone 100 milligrams PO daily. But one thing to keep in mind that's really important about Dapsone is that it has a risk for causing hemolytic anemia. And this risk of hemolytic anemia is higher and much more severe in patients who have a glucose 6-phosphate dehydrogenase or G6PD deficiency. And G6PD plays an important role in red blood cell functions. And someone who has a G6PD deficiency, essentially this causes the red blood cells to become destroyed a lot faster than they can be replaced. And so this causes hemolytic anemia. So keep in mind that if a patient is going to be placed on Dapsone, it is really important that G6PD deficiency testing is completed for the patient prior to starting Dapsone. And this can be done simply through a blood draw and a test done in the laboratory. Other alternatives is going to be atovaquone 1,500 milligrams PO daily with food and pentamidine 300 milligrams inhalation once every 4 weeks. And PJP also has therapy for secondary prophylaxis. And we will start this when they've had prior PJP infections. And the criteria for discontinuing it is when the CD4 count is greater than 200 cells for greater than 3 months. And the criteria for restarting secondary prophylaxis is actually when the CD4 count again starts to drop, but this time less than 100 cells, regardless of their HIV viral load, or if their HIV viral load is above detection, we can restart secondary prophylaxis when their CD4 count is 100 to 200. And the therapy for this is going to be Bactrim, one double strength tablet PO daily, or one single strength tablet PO daily. And the alternative options, again, are the same: dapsone, atovaquone, as well as pentamidine inhalation. So here are just some questions to kind of go over this section. So the first question is, how is P. Girovechi primarily transmitted? I know we're not in person, but I will just give you a couple of seconds. Feel free to pause if you need to think about it a little bit more. But the options are fecal orally, airborne, skin contact, or uncooked meat. And so the answer is airborne. So P. Girovechi is primarily going to be through airborne transmission. Next question is, which of the following is an appropriate regimen for PJP treatment? Is it Bactrim 5 milligrams per kg per day divided into Q6 to 8 hours, atovaquone 750 milligrams BID with food, Bactrim 1 single strength PO TID, or pentamidine 10 milligrams per kg IV daily? So the answer is going to be atovaquone 750 milligrams BID with food. And the others are wrong because for the first option, Bactrim is not 5 mg per kg per day. It's actually 15 to 20 mg per kg per day divided into Q6 to 8. And then if it's not weight-based for option C, it's actually going to be Bactrim 2 double strength tabs PO TID, not 1 single strength. And then for the last option, this is wrong because pentamidine dosing is going to be 4 milligrams per kg IV daily, not 10. Next question is going to be a true false. So corticosteroids increase the incidence of mortality and respiratory failure in patients with PJP. True or false? So this is going to be false, and it's because corticosteroids actually do the exact opposite. They will help decrease the incidence of mortality and respiratory failure in patients with PJP, especially in those who have a PaO2 less than 70. And the next question is, an HIV positive patient is placed on dapsone for PJP prophylaxis. What should be monitored with this therapy? Is it G6PD, serum creatinine, concomitant use with the CYP3A4 inhibitor, or fever? Okay, and the answer to this is G6PD. Again, remember, it is really important to test for G6PD deficiency prior to starting therapy with dapsone, and this is just to decrease the incidence of hemolytic anemia. Okay, now we will be moving on to our next bug, which is Toxoplasma gondii, and this most commonly can cause toxoplasmosis. So T. gondii is a protozoan parasite, and it is prevalent in both humans as well as food animals. And it is actually a worldwide cause of zoonosis. So oocytes sporulate and become infectious only after 1 to 5 days, and it actually can localize in muscle and neural tissue. Most surprisingly, cats can actually shed oocytes, and it is transmitted through ingestion of sporulated oocytes, at least in humans. And different ways that it can be transmitted is through eating undercooked meat, such as pork, lamb, or other wild game meat. Exposure to contaminated cat feces is also another mode of transmission. It is actually really interesting that for pregnant women specifically, they have to wear disposable gloves and wash their hands thoroughly if they're going to be changing a litter box at home. And this is just because of the risk of ingesting or being contaminated or being exposed to these contaminated cat feces and possibly getting toxoplasmosis. Another way is through organ transplant or blood transfusion from seropositive donors. So this is just the same thing that I have already mentioned, but in an illustration form. So these oocytes take a couple of days again to sporulate in the environment and become infective. And then intermediate hosts like birds and rodents actually become infected after ingesting soil or water or even plants that are contaminated with oocytes. And then cats can become infected by consuming these intermediate hosts, such as the birds and the rats. And also animals that are bred for human consumption, like pigs or lamb, can also become infected with these tissue cysts by ingesting, again, oocytes in the environment. And it affects humans, like I said, through eating undercooked meat, consuming food or water that are contaminated with cat feces, blood or transfusion, or organ transplants. And it can also be transmitted transplacentally from mother to fetus. That's why it's really important that pregnant women should not change litter boxes without wearing gloves and washing their hands thoroughly. So clinical presentation and lab findings for toxoplasmosis, it can present as encephalitis, and common signs and symptoms include headache, confusion, motor weakness, as well as a fever, but it can also be disseminated disease and disseminated through the lungs as a pneumonia or even through multifocal organ system failure. And as for diagnostics, imaging and serologies are mostly commonly used to diagnose toxo. But if one or more mass lesions are found on the brain or the brain CTs or MRIs, this is one characteristic, but they also need to have a positive anti-toxoplasma IgG antibody serology. And because of the severity of this disease, therapy is going to typically be initiated with disregard to definitive diagnosis of toxo. And if they respond to the therapy, therapy is going to be continued. But if therapy is initiated and there is no response to therapy, then they will go and conduct a brain biopsy. But typically, this is going to be last line just due to its invasive nature. And brain lesions may not always present as a toxo infection, but can also represent malignancy or cancer. So that is one thing to keep in mind in terms of other differentials. Brain lesions could either present malignancy or it can actually present a toxo infection. And so here I have included a picture of what is seen on a brain biopsy. So this big pink circular thing in the middle is going to be diagnostic of toxoplasmosis. And as for treatment for toxoplasmosis, the therapy is going to include pyrimethamine, 200 milligrams PO as a loading dose, and then it is followed by weight-based pyrimethamine plus sulfadiazine and leucovorin. And so the dosing for those that are equal to or less than 60 kilograms, the pyrimethamine dose is going to be 50 milligrams PO daily. Sulfadiazine is going to be 1 gram POQ6, and leucovorin is going to be 10 to 25 milligrams PO daily. And then dosing differs for those that are greater than 60 kilograms, where pyrimethamine is going to be 75 milligrams PO daily. Sulfadiazine is going to be 1,500 milligrams POQ6, and leucovorin is going to be 10 to 25 milligrams PO daily. There are also alternative options available, and that includes Bactrim 5 milligrams per kg IV or PO BID, atovaquone 1,500 milligrams BID plus or minus leucovorin or sulfadiazine, and the duration of treatment for toxoplasmosis is going to be 6 weeks long. So briefly going over what pyrimethamine is, it is generic for Daraprim. And its mechanism of action is that it inhibits the dihydrofolate reductase enzyme that is found in parasites, and it prevents tetrahydrofolic acid synthesis. But because it causes folate deficiency, it is oftentimes given with leucovorin, and since leucovorin is an active metabolite of folic acid, it will replete essentially what pyrimethamine has depleted. It is also supplied as a 25 milligram tablet. And also keep in mind that this drug has actually been around for decades, probably since the 1950s. And so in the most recent years, obtaining pyrimethamine has been a nightmare and has made its mark in our pop culture. So for those of you who don't know who this guy is, Martin Shkreli, who's been famously dubbed as the Pharma Bro. He took over Turing Pharmaceuticals back in 2015, became the CEO of this pharmaceutical company, and he marked up the price of permethamine from one tablet, one 25 milligram tablet, from $1 to $900. And this is for one tablet also. So imagine a whole treatment course would cost tens or hundreds of thousands of dollars. And this has caused a lot of issues with HIV patients who were diagnosed with toxoplasmosis and were unable to afford the new price. And so obtaining pyrimethamine can only be done now through a direct program and is sent to a specialty pharmacy for the patient to pick up or get delivered directly to them. And so because of this, it enforces studies such as this one right here, the randomized trial of Bactrim versus pyrimethamine sulfadiazine for the therapy of toxoplasmic encephalitis in patients with AIDS. This was a study done back in 1998. And this was a multi-center study where it compared efficacy and safety of Bactrim with standard therapy, which is pyrimethamine and sulfadiazine, for toxoplasmic encephalitis in those who have AIDS in AIDS patients. And so on one arm, they received Bactrim 10 mg per kg per day, and the other arm received pyrimethamine 50 milligrams daily plus sulfadiazine 60 milligrams per kg per day. First arm, there were only 40 patients. The second arm, there was only 37 patients. And they gave therapy for 4 weeks. And at 3 months, they were given chronic maintenance at 50% of the dose that they received for the acute therapy. As for its results, when comparing Bactrim to PS or the standard therapy, clinical response at the end of acute therapy was seen in 65.7% of the Bactrim group compared to 62.1% in the PS group. Radiologic response at the end of therapy was also seen in 62.1% of the Bactrim group compared to only 39.3% in the PS group. And radiologic response was the visualization of lesions and the disappearance of them at the end of therapy. And adverse events was also looked at, and this included any of at least one ADR that occurred throughout the acute therapy phase. And for the Bactrim group, there was only 12.5% compared to 21.6% in the PS group. None of these had significant p-values, but it did essentially show that Bactrim is a safe and effective alternative to pyrimethamine. And because of how hard it is to obtain pyrimethamine nowadays, especially with its increased price, Bactrim is essentially the drug of choice and is what is commonly used for toxoplasmosis treatment, as well as its prophylaxis. So there are 2 instances where adjunctive therapy is warranted in toxo treatment. One of them is corticosteroids, and corticosteroids are given concomitantly when there is a mass effect that occurs due to the brain lesions or due to edema in the brain. And what the mass effect is essentially when there is an increase in the intracranial pressure by any cause. And corticosteroids will help relieve that pressure. But corticosteroids should be discontinued as soon as clinically feasible. Anticonvulsants are also warranted in toxo treatment when a patient presents with seizures or they have a history of seizures. But just keep in mind that this should not be added to prevent any future seizures and should not be used for prophylactic measures. So in terms of prophylaxis for toxoplasmosis, it can be initiated when there is a positive IgG for T. gondii, as well as a CD4 count of less than 100. So it has to meet both of these criteria. a positive IgG for T on the eye, and a CD4 count less than 100. And prophylaxis can then be discontinued when the CD4 count is greater than 200 for greater than 3 months. And if this sounds familiar, it's because it's the exact same discontinuation therapy for PJP. So first line for toxoplasmosis prophylaxis is going to be Bactrim double strength 1 tablet PO daily. An alternative option can be single strength 1 tablet PO daily, and other alternatives include dapsone 50 milligrams PO daily, plus pyrimethamine 50 milligrams per week, plus leucovorin 25 milligrams per week. And another alternative option is atovaquone 1500 milligrams PO daily, plus or minus pyrimethamine 25 milligrams per week, plus leucovorin 25 milligrams per week. Toxoplasmosis chronic maintenance is also something to consider. And when it is initiated is when someone has already completed their toxoplasmosis therapy. And the criteria for discontinuing chronic maintenance in toxoplasmosis is when the patient is finally asymptomatic, or if the CD4 count is greater than 200 for at least 6 months after they've started antiretroviral therapy or ART. And the first line is going to be pyrimethamine 25 to 50 milligrams PO daily, plus sulfadiazine 2 to 4 grams PO in 2 to 4 divided doses, plus leucovorin 10 to 25 milligrams PO daily. And then the other alternative options is essentially swapping out sulfadiazine for atovaquone at 750 to 1500 milligrams PO BID, or Bactrim 1 double strength tablet PO BID, which is going to be the most commonly used in our time today. We will be seeing Bactrim a lot more than we do pyrimethamine. And to close off this section, we will be going over a couple more questions just to refresh our memory and to solidify what we just learned about toxoplasmosis. So the first question is a true-false question. T. gondii is a zoonotic parasite and can be shed by cats. Again, feel free to pause if you need to think about the question a little bit more. But the answer to this question is going to be true. It can be spread from birds or rats to cats, and then cats can shed it in their stool and can be spread by cleaning the litter boxes. And just for completeness sake, it can also be spread by consumption of undercooked meat. Here is our next question. An HIV positive patient is diagnosed with toxoplasmosis and is discharged on Bactrim 5 mg per kg PO BID. How long is treatment duration? Is it 2 weeks, 3 weeks, 6 weeks, or 8 weeks? The answer is going to be 6 weeks long. Next question is, which of the following scenarios should prophylaxis for toxoplasmosis be initiated in an HIV patient? A positive IgG for T. gondii and CD4 count of 134, a negative IgG for T. gondii and CD4 count of 92, a negative IgG for T. gondii and a CD4 count of 155, or a positive IgG for T. gondii and a CD4 count of 71. So the answer is going to be D, a positive IgG for T. gondii and a CD4 count of 71. So the criteria is going to be a positive IgG for T. gondii and a CD4 count less than 100. Next question is, at what CD4 count can secondary prophylaxis for toxoplasmosis be discontinued? A CD4 count less than 50, a CD4 count of 100 for greater than 3 months, a CD4 count of 200 for greater than 3 months, or a CD4 count of 100 for greater than 2 months. And so the answer for this question is going to be C. a CD4 count of greater than 200 for a minimum of 3 months. Okay, and the next one we will be going over is Mycobacterium avium, and this can cause disseminated Mycobacterium avium complex disease. So, Mycobacterium avium complex, or MAC, it is a slow growing mycobacterium, and it's actually composed of two different species, M. avium and M. intracellular. And what it means by slow growing is that these mycobacteria don't typically form on a subculture until about 7 days. So it's a really slow growing bacteria, and it has such a complex cell wall. And because it's also fastidious, meaning it has a complex or particular nutritional requirement for growth, it really won't grow for a really long time. And this infection is also commonly dubbed as the Lady Windermere syndrome. And it is actually named after a character in an Oscar Wilde play known as Lady Windermere's Fan, whose Victorian era manners prevented her from coughing and spitting. And because she never coughed or produced sputum, the organism developed into a respiratory infection, otherwise now known as MAC. So you'll often see MAC being referred to as Lady Windermere syndrome because of this. And transmission, it is ubiquitous in the environment, most commonly in water and soil, but it can be inhaled, ingested, or be inoculated through the respiratory or the GI tract. And keep in mind that person to person transmission is really rare. It can present as a localized disease or a disseminated disease. But when it comes to a localized disease, it can present as lymphadenitis, even pneumonia, or even pericarditis. But when it becomes a disseminated infection, this is actually most commonly seen in those with HIV and those who aren't on antiretroviral therapy. When it comes to disseminated infection, the clinical presentation is usually a fever, night sweats, abdominal pain, as well as diarrhea. And lab findings that you will see that are, again, not specific to the disease is anemia, increased alkaline phosphatase, and increased lactate dehydrogenase. When it comes to diagnosing disseminated MAC, you can visualize this through an abdominal CT, and it will demonstrate lymph node enlargement. You can also isolate MAC from blood cultures or body fluids, and a biopsy can also be performed to visualize and diagnose disseminated MAC. So when it comes to treatment, the first line therapy is going to be macrolide. So azithromycin 500 to 600 milligrams PO daily, plus ethambutol 15 mg per kg PO daily. Clarithromycin can also be used at 500 milligrams PO BID, plus ethambutol 15 milligrams per kg PO daily. An alternative option is on top of the first line therapy of a macrolide plus ethambutol, you can also add on a third or a fourth agent to either of those combinations above. So alternative options include adding on rifabutin 300 milligrams PO daily, adding aminoglycosides such as amikacin or streptomycin in its IV formulation, or you can even add on a fluoroquinolone. Levofloxacin or moxifloxacin PO are most commonly used as alternative options for your fluoroquinolones. When it comes to duration for disseminated MAC, the duration is going to be 12 months long. It's going to be a really long period of time of treatment. And this is just due to the nature of mycobacteria being such a slow growing bacteria. And so a longer duration is warranted in this type of disease. And when discontinuing treatment for disseminated MAC, the criteria that needs to be met is that they need to be asymptomatic, and they also need to have a CD4 count that is greater than 100 for at least 6 months after initiating antiretroviral therapy or ART. And when it comes to prophylaxis for disseminated MAC, the criteria for starting prophylaxis is when the CD4 count drops below 50. And they also have to not be on fully suppressive antiretroviral therapy. And when it comes to discontinuing prophylaxis for disseminated MAC, the CD4 count should be greater than 100 for at least 3 months, or they're taking fully suppressive ART. And when it comes to the actual regimen for prophylaxis, first line therapy is again going to be your macrolides, but the dosing, note that it is different. So azithromycin is going to be 1200 milligrams PO weekly. So this is going to be a once a week dosing, or clarithromycin 500 milligrams PO BID. Alternative options is rifabutin 300 milligrams PO daily, but keep in mind that when initiating this therapy, active tuberculosis should be ruled out prior to starting rifabutin. And so this is one of the studies that changed the recommendations for initiating prophylaxis for MAC. And it essentially takes into account whether or not a patient is on fully suppressive ART. So if we just go back really quick to see when to initiate prophylaxis for disseminated MAC, it's CD4 count less than 50, and the patient has to not be on fully suppressive antiretroviral therapy. This is actually a new recommendation. The old recommendation used to just be initiating prophylaxis when the CD4 count is less than 50, but now they have added on that they should also not be on fully suppressive ART. And so here is one of the studies that changed the recommendations. And it is called, Is Primary MAC Prophylaxis Necessary in Patients with a CD4 Count Less Than 50 who are virologically suppressed on CART? So this looked at 369 patients with no prior MAC infections, and they had a CD4 count less than 50 while they were actually on combination ART. And it analyzed incidence rates of primary MAC infections during 6 months by prophylaxis. So 11 patients had MAC infections within 6 months. But when you look at the incidence of MAC infection and whether or not they were on prophylaxis, 2.28% were on MAC prophylaxis and 3.61% were not on MAC prophylaxis. And you can also see that there were no MAC infections that were observed among 71 patients who were actually virologically suppressed. And the definition for virologically suppressed in this case was less than 100 HIV copies, viral copies. And so 41 of the patients were not receiving MAC prophylaxis, and the incidence of MAC, again, was 0 in both groups. And so essentially, primary MAC prophylaxis may not be required for virologically suppressed patients who are receiving combination antiretroviral therapy. However, this warrants future studies and RCTs to confirm these findings, but essentially this changed the dosing, or this changed the recommendation for prophylaxis and disseminated MAC to include the fact that if they are on fully suppressive ART, that they do not need prophylaxis for disseminated MAC. And again, to close up this section, here are more questions to kind of ask yourselves. So which organisms make up MAC? Select all that apply. Is it M intracellular, M fortuitum, M tuberculosis, or M avium? Again, this is a select all that apply, and I'll give you guys a couple of seconds. So the answer is going to be M intracellular and M avium. These are going to be the 2 organisms that make up MAC. The next question is, which agent is preferred for opportunistic infection prophylaxis against disseminated MAC? Your options are Bactrim double strength, azithromycin, dapsone, or fluconazole? And the answer to this is going to be B. It's going to be your macrolides. So azithromycin in this case is going to be the correct answer. Azithromycin or clarithromycin are going to be your preferred opportunistic infection prophylaxis against disseminated MAC. Next question is going to be a true false question. An HIV positive patient is on fully suppressive ART and a CD4 count of 12. Prophylaxis against MAC is warranted. Is this true or false? And the answer to this is going to be false. So remember, if a patient is on fully suppressive ART, regardless of their CD4 count, they do not need to be put on prophylaxis against MAC. Okay, now moving on to our next organism. This is going to be Candida albicans, and Candida albicans can cause oropharyngeal and esophageal candidiasis in those who are immunocompromised. So, C. albicans, this is a yeast that can colonize both the gastrointestinal as well as the genitourinary tract, as well as the skin. And it accounts for nearly all mucosal candidiasis, and it is most common cause of invasive disease. So risk factors for infection caused by C. albicans, um, those who have cellular immune deficiency states such as HIV and AIDS will be at high risk for infection by C. albicans. And patients who are treated with antibiotics are also at risk for infection. And if you think about it, it's because antibiotics will disrupt microbiota within the GI and the GU tract. And this allows Candida to take advantage and cause infection. Chemotherapy, radiation therapy of the head and neck is also the same idea where your GI tract cell lining is killed off by chemotherapy and radiation. And so this disrupts the normal microbiota in your body and allows C. albicans to then take advantage and cause infection. And lastly, those who are treated with inhaled glucocorticoids for asthma or rhinitis are also at risk for infection by C. albicans. So as for clinical presentation, there are two types of infections that can occur in candidiasis, and that is oropharyngeal candidiasis, also known as thrush, and esophageal candidiasis. So breaking it up between the two, starting off with oropharyngeal candidiasis or thrush, clinical presentation can include cotton mouth, loss of taste, and patients can either present with pain with swallowing or eating or not. It really just depends on the severity of that thrush. But when it comes to esophageal candidiasis, this is going to be most commonly seen in a lot of HIV patients. But the most common clinical presentation, again, you may see cotton mouth, but the main thing you will see in these patients is pain with swallowing. When it comes to diagnosing candidiasis, for oropharyngeal candidiasis, you will see presence of white plaques on the buccal mucosa, the palate, as well as the tongue or the oropharynx. And by scraping these lesions and performing a gram stain or a potassium hydroxide preparation, you'll be able to see growth of candida. When it comes to diagnosing esophageal candidiasis, you may see white mucosal plaque-like lesions, and sometimes endoscopies are performed so you can see the extent of the infection down the esophagus, and you will be able to see all of this through an endoscopy as well. A confirmatory biopsy is oftentimes conducted when confirming diagnosis of candidiasis. So this picture up here, this is the oropharyngeal candidiasis or thrush. And here is a picture done through an endoscopy where you can see the presence of the white plaques. And so this growth is actually candida. So for treating candidiasis, I've again broken them down between the oropharyngeal candidiasis and esophageal candidiasis. So focusing our attention right now on oropharyngeal candidiasis, first line is going to be topical treatment. And you can see why topicals are warranted in this case, and that's just because of the localization of the disease within the mouth. So first line include clotrimazole troches, 10 milligrams 5 times a day, or even using miconazole mucoadhesive buccal tabs. And the dosing for that is going to be 50 milligrams a day. Another first line option is nystatin suspension, and this is going to be a liquid suspension of 5 milliliters. And the patient needs to swish and swallow this 4 times a day. Alternative options can be systemic options, so either PO or IV fluconazole at 200 milligrams times 1, and then they will continue on with a decreased dose of 100 milligrams PO daily. And for thrush, the duration of treatment is only going to be 1 to 2 weeks or 7 to 14 days. So when it comes to esophageal candidiasis, topicals will not be warranted in this case, just because of the possible extent of the disease going down all the way through your esophagus. Systemic antifungals are going to be your drug of choice. So the first line option is going to be fluconazole, 400 milligrams, either PO or IV times 1, and then 200 to 400 milligrams daily. And alternative options are your echinocandins, and that includes micafungin, caspofungin, as well as anidulafungin. But just keep in mind that there have been reports of higher rates of relapse in echinocandins compared to azoles. That's why our fluconazole is going to be our first line therapy. And the duration of therapy for esophageal candidiasis in comparison to thrush is going to be a little bit longer. So instead of 1 to 2 weeks, the duration is going to be 14 to 21 days, or essentially 2 to 3 weeks. So remember again, topicals are going to be your first line for oropharyngeal candidiasis, and systemic antifungals will be your first choice for esophageal candidiasis. And when it comes to prophylaxis, prophylaxis for candidiasis is actually not recommended. And because of the risk of mucosal disease is a lot lower than the risk of drug resistance in Candida strains. So candidiasis is actually associated with relatively low morbidity and mortality. And when it is detected, therapy is highly effective. So essentially, prophylaxis is not going to be warranted because, again, this will also help prevent drug resistance by Candida. So prophylaxis for candidiasis, not recommended. And to close off this section, we will go ahead with a few questions again. So true, false. Topicals are recommended first-line options for treatment of esophageal candidiasis. True or false? Again, esophageal candidiasis. The answer is going to be false. And again, esophageal candidiasis, you want to start with systemic antifungals. Topicals are going to be your first line for oropharyngeal candidiasis. Next question is another true false. Prophylaxis for oropharyngeal and esophageal candidiasis is recommended for HIV positive patients. Is this true or false? The answer is going to be false. Prophylaxis is not recommended for candidiasis. Next question, an HIV positive patient presents with white plaques on his tongue and mouth. He is diagnosed with oropharyngeal candidiasis. Which treatment would you recommend? A, fluconazole 800 milligrams IV daily. B, miconazole 50 milligrams IV daily. C, nystatin suspension 5 mils swish and swallow 4 times daily. Or D, clotrimazole troches 100 milligram PO/BID. And so The answer is going to be C, Nystat in suspension, 5 mils, swish and swallow 4 times daily. And let's briefly review the other treatment options. So again, oropharyngeal candidiasis is located in the mouth, and topicals are first line. So A and B are incorrect. And when it comes to the clotrimazole troches, 10 milligrams 5 times a day is the correct dose, not 100 milligrams POBID. And just for completeness sake, in terms of our duration, we are going to be looking at 7 to 14 days for oropharyngeal candidiasis. Okay, now we will be moving on to Cryptococcus species, and this will cause cryptococcal meningitis. So Cryptococcus, it's a yeast-like round fungus, and Cryptococcus neoformans and gattii are going to be the most common species. It is found in soil and can also be found in high levels of pigeon droppings. And patients who have HIV, AIDS, or even cirrhosis are actually at a higher risk for infections caused by Cryptococcus species. And its pathogenesis, it is transmitted as spores and can be transmitted through inhalation. And although any organ can be involved, it commonly presents as meningoencephalitis. And so the picture on this right is essentially showing imaging of Cryptococcus meningitis. And you can see the Cryptococcus spores that are found within this brain. And this just shows, again, the transmission of Cryptococcus. It can be found in the environment or from bird droppings, and these spores are then inhaled into the lungs. And once they are located in the alveoli, they can start to disseminate into the central nervous system in humans. So as for clinical presentations and lab findings, signs and symptoms of meningoencephalitis include fever, malaise, headache, and even your traditional meningitis signs. So it may present more so as an encephalopathic disease, and this includes lethargy, seizure, dementia, as well as altered mental status or AMS. And those that are found with cryptococcal meningitis typically have elevated intracranial pressures of greater than 20, but this is most commonly and most frequently seen in HIV patients. In terms of cultures, it is more likely to become positive in the CSF than in the blood, but you can see cryptococcus positive in the blood about 50% of the time, compared to 80% of the time when found in CSF cultures. And a CSF culture is obtained by a lumbar puncture, or LP. Diagnosis can also be made if there is a positive cryptococcal antigen found. And another common diagnostic test is looking at cryptococcus through India ink stainings of the CSF. So performing India ink stainings of the CSF can identify cryptococcus, but one thing to keep in mind that this is only a stain and not a culture. So what you can, if you do visualize cryptococcus on an India ink stain, this doesn't represent true growth or true infection because it may just represent dead organisms. But it will demonstrate encapsulated yeast in about 60 to 80% of the cases. And as you can see in this picture above, this is what it would look like under an India ink stain when cryptococcus is found. So it's a cell with this encapsulated yeast found on the inside. And then just keep in mind, again, that this could just represent dead organism since the stain does not represent true growth of that organism, but just detection of it. So cultures are going to be really important in this case, and whether or not you will see growth of cryptococcus. So treatment for cryptococcal meningitis is actually done in 3 different phases: induction, consolidation, as well as maintenance. And so, as for induction treatment, first line is going to be liposomal amphotericin B, or LAMB, 3 to 4 milligrams per kg IV daily, plus flucytosine 100 milligrams per kg PO daily, that is divided into 4 doses. And this entire regimen is going to be for a duration of 2 weeks. Keep in mind that flucytosine is going to be really adjusted. And an alternative option, if either the liposomal amphotericin B or the flucytosine is unavailable, you can substitute that unavailable product for fluconazole. So that essentially is, if flucytosine is going to be unavailable, you can substitute flucytosine for fluconazole, or if liposomal amphotericin B is going to be unavailable, you can alternate that with fluconazole. So the available options for alternates can be LAMB plus fluconazole, or flucytosine plus fluconazole. And the reason why we don't use fluconazole as monotherapy is because fluconazole is a fungistatic therapy. And this essentially means that it will only inhibit further growth of Cryptococcus, but will not kill off current organisms. So we don't want to use fluconazole monotherapy, because we will need an agent that is we're going to want to use an agent that is not fungistatic. So the ones that are not fungistatic is going to be liposomal amphotericin B or flucytosine. And these are going to be your fungicidal agents. And that's because with serious meningitis infection by Cryptococcus, we want to be able to kill off that current organisms that are there, not just inhibit its further growth. So substitution is only allowed and not full replacement by fluconazole monotherapy. There was actually a new study done this year looking at high dose LAMB as only a single dose when treating cryptococcal meningitis. So the study was single dose liposomal amphotericin B treatment for cryptococcal meningitis. And this was actually a study done this year. It was a phase 3 randomized controlled non-inferiority trial, and it looked at high dose LAMB 10 milligrams per kg on day 1 only. And then it was followed by 14 days of flucytosine plus fluconazole. And the other was amphotericin B deoxycholate 1 mg per kg per day times 7 days, plus flucytosine times 7 days, followed by fluconazole times 7 days, which is standard therapy. So the high dose LAMB is actually one arm, and then the amphotericin B deoxycholate is the second arm. So it looked at death from any cause at 10 weeks, and the results actually showed that this primary endpoint was seen in 24.8% in the LAMB group compared to standard treatment with the amphotericin B deoxycholate group, with a difference of negative 3.9% points, and it was also seen to be within the non-inferiority margin. It also had a p-value of less than 0.001. And another thing that they looked at was any grade 3 or 4 adverse events. And you can see that in the LAMB group, there was only 50% seen and 62.3% in the standard treatment, with a p-value of less than 0.001. And so essentially, it showed that single dose LAMB plus flucytosine plus fluconazole was non-inferior to standard treatment with the amphotericin B deoxycholate. And although this isn't current practice or reflected on any guidelines, this may become the future of cryptococcal meningitis treatment, and just doing a one-time dose of high dose liposomal amphotericin B. The next phase is going to be your consolidation phase. And consolidation phase can start once there is CSF sterilization that has been achieved. And this is done through lumbar puncture and repeat CSF cultures after induction therapy is completed. So CSF culture done by LP is going to be done when induction therapy is completed at the 2-week mark. And CSF sterilization is achieved when there has been clinical improvement as well as a negative CSF culture. And once this is done, we can finally start consolidation treatment. And the therapy first line is going to be fluconazole, 400 to 800 milligrams per day. And the duration for this is going to be 8 weeks long. Alternative options is a different azole, which is itraconazole, and the dosing is going to be 200 milligrams BID, also for 8 weeks. So, as a recap, consolidation therapy duration is going to be 8 weeks, and induction therapy is going to be 2 weeks. After you finish induction and then moved on to consolidation and finish your consolidation treatment, we will then do a chronic maintenance for cryptococcal meningitis. So after the 8 weeks of consolidation, maintenance therapy is going to be continued for further long-term suppression. And the duration is going to be at least a year, but they must meet the following criteria in order for you to be able to stop chronic maintenance. So they must have received ART, have a CD4 count that is greater than 100, a viral load that is undetectable for more than 3 months. And once they're able to meet all of these criteria, they can finally stop maintenance treatment for cryptococcal meningitis. But again, they have to at least had maintenance of 1 year from initiating antifungal therapy. So from the start of when they had induction therapy, that's going to be the start of your 1 year. And it's not 1 year from starting maintenance. So when it comes to reinitiating treatment, you want to consider this when the patient's CD4 count drops to less than 100. And one thing that is really important about cryptococcal meningitis when it comes to initiating ART therapy is that ART is actually going to be delayed for at least 4 to 6 weeks after the diagnosis of cryptococcal meningitis. And I will go into more depth about this at the end of this lecture, but just remember that we don't start ART right away in an HIV patient that is diagnosed with cryptococcal meningitis. There's going to be a delay. And don't worry, I'll be going into further depth about the reasons why later on. So we will be revisiting this later. But just remember that there is going to be a delay. And then so just to recap, because there's so many different phases in cryptococcal meningitis treatment, we're going to start with 2 weeks of induction therapy, where this is where we are going to decrease that load of the organisms that are found in the brain. And then after that 2 weeks of induction, we will be moving on to consolidation. And consolidation phase is not going to be started unless we do see negative CSF cultures and improvement in symptoms. And that is going to be 8 weeks of consolidation. Once 8 weeks of consolidation is done, then we will be moving on to chronic maintenance. And the duration overall is going to be 1 year from initiating antifungal therapy. So from that first day that we have started antifungal therapy, we will be starting to count down 1 year. And at 1 year, we can then start to look at whether or not we can discontinue treatment. And when it comes to discontinuing treatment after 1 year of initiating that antifungal therapy, they need to be at least receiving ART. Their CD4 count has to be greater than 100, and their viral load has to be undetectable for more than 3 months. Okay. So now let's go into some questions about cryptococcus meningitis. What opportunistic infection does cryptococcus most commonly present as? Osteomyelitis, meningitis, colitis, or pancreatitis? The answer is meningitis. Next question. Which of the following are risk factors for cryptococcal meningitis? And this is going to be a select all that apply question. Is it exposure to rats, cirrhosis, exposure to bird droppings, or uncooked meat? The answer is going to be cirrhosis and exposure to bird droppings. Next question is, at what stages is fluconazole monotherapy warranted in cryptococcal meningitis treatment? Also, a select all that apply. Is it during the induction phase, consolidation phase, or the maintenance phase? And the answer is going to be consolidation as well as the maintenance phase. So remember, fluconazole monotherapy is not recommended in induction therapy because of its fungistatic nature, but we will use liposomal amphotericin B and flucytosine in the induction phase. But when it comes to the consolidation and the maintenance phase, we actually will see fluconazole being monotherapy. And now moving on to our last bug, this is cytomegalovirus, and it can manifest in many ways, such as retinitis, colitis, and esophagitis. So cytomegalovirus, it is a double-stranded DNA herpes virus, and it actually establishes lifelong latency after primary infection. So it will never completely go away, but it will then have to be established as a lifelong latent virus. And when the virus is detected, it is already defined as a CMV infection. And it can either be localized or disseminated, but can also cause end organ disease in HIV patients, especially those who have a really low CD4 count. And that CD4 count is of less than 50 cells. Cytomegalovirus can be transmitted sexually as well as close contact. Blood or tissue exposure can predispose someone to cytomegalovirus, as well as it being transmitted perinatally. So there are different manifestations of CMV. And like I mentioned, it can present as retinitis, colitis, esophagitis. It can also present as neurologic disease. But again, I just wanted to reiterate that we have been talking this entire time mainly about opportunistic infections in HIV patients. And so retinitis is going to be the clinical manifestation of CMV most commonly found in HIV patients. And those who present with CMV retinitis, you will see them have fluffy yellow-white retinal lesions. And most commonly, you will see that there's a lesion border that is found between the infected and the normal retina. And that is very characteristic of CMV retinitis. When it comes to CMV colitis, you can see this in about 5 to 10% of patients in HIV. And they will present with weight loss, anorexia. They will sometimes present with abdominal pain. Sometimes you'll see that there is colon and cecum perforation. And even through CTs of the abdomen, it can also show colonic thickening. When it comes to CMV esophagitis, you'll see patients typically present with odynophagia, nausea, as well as retrosternal discomfort. For neurologic disease, there's many different types of clinical manifestations for CMV neurologic disease. This includes dementia, ventriculoencephalitis, and you'll see that these symptoms will progress over several weeks rather than it being more of like an acute presentation. There are also different gold standards for diagnosing these different manifestations. So specifically for retinitis, you will see retinal changes observed during ophthalmoscopic examination, or you can see this through a PCR of aqueous vitreous humor. You can see CMV through the PCR amplification. When diagnosing colitis or esophagitis, a biopsy with pathology showing viral inclusions is the gold standard for diagnosing this. And for neurologic disease, the presence of CMV found in CSF brain or brain tissue through PCR amplification is the gold standard for diagnosis. So I will go into all these four different treatments for retinitis, esophagitis, colitis, as well as neurologic disease. So our first one is going to be CMV retinitis. And first line is actually going to be ganciclovir, 5 milligrams per kg per dose IV, Q12. And this is actually going to be 14 to 21 days. And then it's going to be followed by chronic maintenance therapy of ganciclovir, 5 milligrams per kg IV daily. Another first line option is IV ganciclovir induction, 5 mg per kg Q12, again for 14 to 21 days, but instead of being followed by IV daily dosing, it is followed by PO valganciclovir, 900 milligrams PO daily. Or you can also use valganciclovir 900 milligrams PO Q12 for 14 to 21 days, followed by valganciclovir 900 milligrams PO daily. And all of this can be in addition to or intravitreous injections of ganciclovir or foscarnet. And you'll typically see intravitreous injections be used when these lesions are sight-threatening. An alternative therapy for CMV retinitis is going to be foscarnet 60 milligrams per kg IVQ8 or 90 milligrams per kg IVQ12. And again, the same duration of 14 to 21 days. When it comes to discontinuing chronic maintenance, CMV, you need to see CMV treatment for at least 3 to 6 months. You have to also be able to visualize inactive lesions. CD4 count has to be greater than 100 for at least 3 to 6 months in response to ERT. And lastly, they have to be seen and consulted with an ophthalmologist to visualize the eye. And keep in mind for when we go over colitis, esophagitis, as well as neurologic disease, the dosing is going to be the same as the retinitis dosing. So when it comes to CMV colitis or esophagitis, the preferred agent is going to be IV ganciclovir. But PO valganciclovir can be initiated once the patient is able to tolerate and absorb PO medications. Duration is going to be only 21 to 42 days or until signs and symptoms have resolved. For CMV neurologic disease, well-documented therapy hasn't really been extensively studied in this case, but given the really poor outcomes found in CMV neurologic disease, you will oftentimes see IV ganciclovir plus IV foscarnet used concomitantly. And the role of PO valganciclovir has not been established. So just keep in mind that PO valganciclovir is going to be common therapy for colitis, esophagitis, as well as retinitis, but you won't really see it be used in neurologic disease just because there hasn't really been much studies using and seeing the effects of PO valganciclovir in neurologic disease. And although IV ganciclovir and IV foscarnet poses a great risk of different toxicities, the risk of its poor outcomes is greater than the risk of these toxicities. So really, you just want to give as many therapy as possible for those seen with CMV neurologic disease just because of their poor outcomes. And the duration hasn't really been established in this disease state, but really it just depends on how long they've been experiencing signs and symptoms. And that's how long duration is going to be really based off of. And for completeness sake, I wanted to include this slide about transplant prophylaxis. I know we've been mostly talking about HIV infections, But just for your information's sake, this won't be on the exam, but just for everyone to be aware that there is actually transplant prophylaxis for CMV infections. And so it's not just typically warranted in HIV patients, but those who receive transplants are also at risk for CMV infections. And there are two types of prophylaxis in this case. There's universal prophylaxis and there's preemptive therapy. And the difference between universal prophylaxis and preemptive therapy is that universal prophylaxis involves administering antivirals to all transplant recipients, irrespective of the risk of CMV disease. And preemptive therapy involves directing prophylaxis only toward those that are high risk transplantation recipients. And this is essentially an attempt to prevent the progression of asymptomatic infection into a CMV disease. So, when focusing on universal prophylaxis, you'll typically see this in those who may be CMV seropositive or receive a CMV seropositive donor, and most specifically in those that are donor positive or D plus or recipient R plus patients. They will start universal prophylaxis 10 days after their transplant. And so, most specifically, for those who are CMV donor positive and recipient negative, vanciclovir 900 milligrams PO once daily for 6 months is warranted in this patient population. For those who are CMV recipient positive patients, you'll see valganciclovir 900 milligrams PO once daily for only 3 months. And so you'll notice that there is a shorter duration in those that are recipient positive, just because the duration for donor positive is going to be much greater just because they are receiving that donor positive organ. When it comes to preemptive therapy, this is going to be started in early asymptomatic patients who have CMV viremia. And again, it's to prevent symptomatic disease and late onset CMV. Preemptive therapy is going to be started at less than 100 days after transplant, typically. And the therapy used is valganciclovir 900 milligrams PO BID. And the duration is going to be guided typically through viral load monitoring. So to close off our CMV talk, here again are a couple of questions. First question is, which of the following are appropriate agents for treatment of CMV colitis, esophagitis, as well as retinitis? Is it A, valganciclovir, B, valacyclovir, C, ganciclovir, or D, acyclovir? And the answer is going to be valganciclovir and ganciclovir. The next question is, an HIV positive patient completed 6 months of valganciclovir for CMV retinitis. What criteria must be met for chronic maintenance to be discontinued? Select all that apply. Inactive lesions, consult and clearance by ophthalmology, a CD4 count greater than 100 cells for 3 to 6 months in response to ART, or chronic maintenance should be continued for life. And so the answer to this is A, B, and C. Inactive lesions, consult and clearance by ophthalmology, and CD4 count of 100 cells for 3 to 6 months in response to ART. Next question is, how long is treatment for CMV esophagitis? Is it 21 to 42 days, 7 to 14 days, 14 to 21 days, or 3 to 6 months? And the answer to this is going to be 21 to 42 days. So I just wanted to end this lecture talking about iris, what that is, and how it affects opportunistic infections. And so, iris is an immune reconstitution inflammatory syndrome. And it is a paradoxical worsening of pre existing infectious processes once ART is started. So, this is going back to why ART isn't going to be started right away after cryptococcal meningitis is diagnosed, and why there is a delay for starting ART. So, in HIV, CD4 count is low and HIV viral load is high, right? When ART is initiated, the exact opposite happens. Your viral load will start to go down and your immune system starts to build back up CD4 cells and other immune cells. Again, once ART is started, there's actually a greater than 90% reduction in overall viral load within the first 2 weeks. And so, again, reiterating that when viral load starts to go down, your immune cells, such as your CD4 lymphocytes, starts to go back up. And your immune system hasn't been active in a while. And so now that it is active again, is actually flooding the body with immune cells. And it starts to over respond to pre existing infections. So your immune system starts to detect dead bugs of opportunistic infections that were previously treated. And T cells may react to them and fight it off and ramp up your immune system, causing iris. And it does it in two ways. Your immune system gets stronger and then start to fight off these non-detectable opportunistic infections and go overboard on the release of cytokines, other immune cells, or when your CD4 count was really low, opportunistic infections may still be present, but they might have not caused any symptoms in the patient. And so they typically just go off and become undetectable in the body. But now that your CD4 count is starting to ramp up again, it will react to these low, undetectable pathogens or organisms found in your body and will really just overreact and have an overactive immune response. And iris only happens in about 20% of patients who start ART, but the risk really depends on the likelihood of there already being a pre existing opportunistic infection and how your immune system will respond to ART. So, again, to reiterate that, your CD4 count is going to be low in HIV. And once antiretroviral therapy is started, the HIV viral load is going to go down. And with your CD4 count going up and the initiation of your immune system starting to ramp up again, it's going to react to either dead organisms or low levels of live organisms that are non-detectable and cause asymptomatic infections in these patients. And so your immune system is going to start to cause this inflammatory syndrome, and your body is going to react to that. So common pathogens that are associated with iris include MAC and tuberculosis, Cryptococcus, P. girovecii, CMV, HSV, HPV, as well as HHV8. And it is going to be managed typically by steroids, and in most cases will resolve fairly quickly. But in those that are ART naive and HIV positive, ART can be initiated within 2 weeks of most opportunistic infections, except in two cases: cryptococcal meningitis and tuberculous meningitis. The reason for this is that the benefits of starting ART is greatly outweighed by the manifestations of potentially serious iris secondary to these opportunistic infections. So this is going to be one of the main reasons why you don't start ART right away in cryptococcal meningitis. You want to wait at least 4 to 6 weeks after the diagnosis. And that is just because within those first 2 weeks, you may experience iris, and you don't want to start ART in that case. And lastly, I just have these summary charts of treatment and prophylaxis just to make it easier to visualize the differences in therapy for each organism and their specific opportunistic infection, as well as their duration. So, just to reiterate, for the treatment of PJP, Bactrim is going to be your drug of choice for 21 days. Toxoplasmosis, pyrimethamine is drug of choice, but is also weight based. But then again, just remember that with how difficult it is to obtain pyrimethamine, Bactrim it can be a good alternative. And the duration for toxoplasmosis treatment is going to be 6 weeks. For disseminated MAC, you will use azithromycin in conjunction with ethambutol or clarithromycin, and it will be for 12 months, and they have to be asymptomatic, CD4 count greater than 100 for greater than 6 months after initiation of ART in order for you to discontinue disseminated MAC treatment. For oropharyngeal candidiasis, clotrimazole troches, or miconazole mucoadhesive buccal tabs for 14 days. Esophageal candidiasis is going to be fluconazole for 14 to 21 days. Cryptococcal meningitis, again, we have 3 different phases: induction, consolidation, as well as maintenance. And induction is going to be for 2 weeks with LMB plus flucytazine. And then consolidation is going to be with fluconazole for 8 weeks. And maintenance is also fluconazole. CMV retinitis, you can use either ganciclovir, IV ganciclovir, followed by PO valganciclovir or just valganciclovir. And this is all plus or minus intravitreous ganciclovir, depending on how life-threatening the retinitis can be on site. CMV colitis and esophagitis is also ganciclovir, and this can also be done with PO if they're able to tolerate. And this will be for a duration of 21 to 42 days or until signs and symptoms have resolved. For a CMV neurologic disease, ganciclovir IV plus foscarnet is typically used. And again, optimal duration has not really been established in this disease state. And here is just a summary table of prophylaxis for PJP toxoplasmosis as well as disseminated MAC. And just to look at the different criteria for initiating prophylaxis, what is the preferred prophylaxis regimen, and criteria for discontinuing prophylaxis. And I apologize for this, but your slides may not have this. But remember that criteria for MAC prophylaxis is CD4 count less than 50 and not on fully suppressive ART. So just remember that part. I think that part is not included in the slides that I provided you. But when it comes to discontinuing prophylaxis, again, CD4 count is greater than 100 for 3 months, or they are already taking fully suppressive ART. And I just wanted to close off this lecture with a case question. So, AK is a 59-year-old male who presents to the ED for altered mental status and fever. He was diagnosed with HIV 3 months ago. He doesn't have any known drug allergies, past medical history of HIV where he was diagnosed 3 months ago, hyperlipidemia, hypertension, COPD, and seizures. These are his home medications. And upon physical exam and his vitals, everything seems pretty stable. Pleasant, non-ill appearing male, no acute pulmonary abnormalities. He is currently NPO. White blood cell count is 8.1. That is his H&H. His serum creatinine is 0.82. But he is positive for Toxoplasma IgG. And he also has a CD4 count of 78. His imaging shows presence of ring-enhancing lesions in the basal ganglia, but his chest X-ray doesn't show any acute pulmonary findings. Which opportunistic infections are we concerned for? Again, if you need to pause, go over these questions one by one before reviewing the answers with me, you can go ahead and do that. But the first two questions to keep in mind is which OIs are we concerned for, and would you recommend treatment for this patient? If so, what dose and duration? So for the first question, which OIs are we concerned for? It's actually going to be toxoplasmosis. And as for treatment, toxoplasmosis treatment is going to be Bactrim 5 milligrams per kg IV. And in this case, it would actually be 425 milligrams of trimethoprim dosed in a BID dosing. The next couple of questions is adjunctive therapy warranted in this patient? If so, what would you recommend? And the question after that is, what is the duration of toxoplasmosis treatment? So the answer to number 3 is going to be yes, adjunctive therapy is warranted in this patient. And this is because this patient has a history of seizures. So you want to start anticonvulsants in this case. The answer for number 4 is what is the duration of toxoplasmosis treatment? And this is going to be 6 weeks. Last two questions. Once treatment duration is complete, would you recommend prophylaxis? If so, what opportunistic infections are we concerned for? And what is the recommended agent and dose? And the last question is, when can prophylaxis be discontinued? Go ahead and pause if you need more time, but just to answer these questions, yes, we would recommend prophylaxis, and the opportunistic infections that we are concerned for is PJP and toxoplasmosis. And with this, we can recommend Bactrim double strength PO BID. And prophylaxis can be discontinued when the CD4 count is greater than 200 for at least 6 months after ART initiation for toxoplasmosis. But the criteria is, again, different for PJP. So just keep in mind that for PJP, you want to make sure that CD4 count is greater than 200 for greater than 3 months. And with that, that is the end of my lecture. Again, thank you so much for having me teach you guys opportunistic infections. And again, here is my email for whenever you guys have any questions after reviewing this lecture. And yeah, feel free to email me for any questions, and good luck for the rest of your semester. Thank you so much for having me.